Hi, I'd like to thank the Irish Cancer Prevention Network for inviting me to present at this webinar. My name is Caroline Mason Mahon. I'm a consultant in public health medicine and I'm the Public Health Director in the National Screening Service. I've been asked to tell you a little bit about the work we're doing on equity and social inclusion. I only have a very short time, so I'll whip through as much as I can. So equity is really important to us in screening because it affects the outcomes from the programmes. If we don't get good representation in our screening services from all sectors of society, we're at risk of increasing the health inequalities across the population rather than decreasing them with this population health intervention. There are 3 cancer-related screening programmes in Ireland: breast check, cervical check and bowel screen. And I've got a resource slide at the end of this talk that will link you to details of those programmes if you're interested. Taking part in screening is a choice, and in the National Screening Service we take a lot of care when we develop information to ensure that they can make an informed choice about taking part in our programmes. And this is important because screening programs aim to improve the health of the population, and in doing that they do improve, for some people, their own personal health, but there's also a risk that they can cause harms, and one of those harms, for example, is over-diagnosis and over-treatment. So we want people to be very aware of what they're getting into with the population screening program, and that they make an informed choice of what is right for them. So to do that, we need to understand how they make choice. So this is taken from vaccine hesitancy evidence. Confidence, complacency, convenience, communication and context all affect how people make their decisions. And we pay attention to all of these in screening, but today I suppose I'm going to talk to you more about the convenience of it, the access to our services, communications and the context in which people make decisions. So that talks about really their environment, their ethnic background, or whether they're members of any particular marginalised group, where there could be structural issues in our society that prevent them making a good choice for themselves around screening. Our own research in the NSS supports that. We know that low knowledge about screening, fear of what might be found, ability to access our services and their feelings about whether our services are trustworthy or not all affect people's ability to decide what to do when they're offered an opportunity to take up screening. For people who make that choice, some of them still have access as a problem, and so that is one of the areas that we take very seriously as well. So what are we doing about this? Well, access is one of them. We have 4 access officers who are senior health promotion officers, and they give individual support and help to people who contact them who have access issues. But they also take the learning from those contacts to ensure that we can help other people across the population. And the sort of things that have come from that work that they do is we've developed easy read resources, we've developed Braille resources, translated resources, both videos and written, large font resources, and we've also had success in increasing the number of mobile units that are available for breast checks so that the screening can be done close to people's home. We also work with communities, and we've been engaging with them to understand the specific needs that the particular communities have. And so, for example, so far, we've done a needs assessment with the LGBT+ community, which has given us great insights into what affects them accessing screening. And Cervical Check are now implementing an action plan from that work. We're working collaboratively with disability groups to do a needs assessment and understand how we can improve our services for them. And these will be finished later on in the year and for implementation from next year. The translated resources that I mentioned earlier were done as a co-design project with migrant communities supported by social inclusion in the HSE and health advocates. And those are available at the asylum seeker centres as well. Another area that we do a lot of work on is training and education. We recently worked with Pave Point and one of the community health organisations to design and deliver training for traveller peer health workers and that's to support them in supporting their own community in making a choice about screening. And we know that travellers often have lower access and usage of health services and screening. We also did a similar piece of work with intercultural health advocates. So it's important to work with communities because we can be oblivious to what their needs are unless we ask them. And there are many cultural influences on their health as well that need to be taken into consideration. If we don't work with the communities, then we can end up with solutions that completely miss what the problem is for them. We also in the NSS have been improving our patient voice input to our services. And we have a public patient partnership strategy, which is currently in implementation. And finally, we're going to draw all of this work together into an equity framework, starting in the next few months. And again, that will be guiding from next year the work that we do in the future around trying to improve equity and address social inclusion issues that prevent people from getting full benefit of these publicly funded population health programs. So thank you for listening, and I'll just leave you with the resource slide that I have, and I'm happy to share these slides after the webinar. Thank you.